This lesson in 405A is dysrhythmia therapy, antiarrhythmics, pacemakers, ICDs, cardioversion, and defibrillation. Lesson objectives. I'm going to go over the major classifications of antiarrhythmic drugs, differentiate between temporary versus permanent pacemakers, care of the patient with a newly implanted ICD, and care of the patient with a newly implanted pacemaker, cardioversion and defibrillation, indications for both and differentiate between them, and the use of hypothermia and nursing implications in the care of cardiac patients. Most common dysrhythmias are often going to be encountered in a clinical setting: sinus tach, sinus brady, PACs, PVCs, atrial fib, SVT, and ventricular tachycardia. These rhythms I went over in my previously recorded EKG lesson. Please refer to that lesson so that you're comfortable and knowledgeable about these rhythms. Antiarrhythmic drugs. Classification is listed, the mechanism of action and the drugs, and I would expect you would go through and be able to recognize these at this level in the program. Procainamide is, a sodium channel blocker intermediate, the lidocaine, sodium channel blocker fast, flecainide, sodium channel blocker slow. You have your beta blockers, metoprolol and propranolol, potassium channel blockers, which prolong that refractory period, so that would be your amiodarone, your Solol, calcium channel blockers such as diltiazem or verapamil, and then other antiarrhythmic drugs such as digoxin, adenosine, and magnesium sulfate, which we also use as well. So lidocaine indications are ventricular dysrhythmias, oftentimes given as IV push, 1.5 mg per kilogram, and we may repeat it after 5 minutes, and many times these patients will be on a drip. Contraindications would be somebody with heart block. You wouldn't really want to be using lidocaine with, or Wolff-Parkinson-White syndrome, which is a tachyarrhythmia. We wouldn't really want to be using it in those patients either. Adverse reactions with lidocaine is that hypotension, the heart block, the bradycardia, and a proarrhythmia, which means it could actually potentiate the arrhythmia that we're trying to get rid of. So proarrhythmia, it actually makes it worse. Nursing considerations, obviously, is continuous cardiac monitor. We're going to be looking at fluid electrolytes, and we're going to be monitoring for lidocaine toxicity. And I would expect you would recognize what those toxicities are with lidocaine, but certainly the drowsiness that can come across, or its change in level of consciousness. So a patient is ordered 1 mg per kilogram stat. How many ml would you give if the patient weighs 80 kilograms? And this would be an example of the math problem that I would expect you to be able to solve. So metoprolol, or low pressor, indications: tachyarrhythmias, hypertension, CHF. The mechanism of action, it preferentially blocks beta-1 receptors, the myocardial adrenergic receptors. Usually does not affect beta-2 receptors, which are in the pulmonary, vascular, or uterine. However, it can affect some, but it generally is preferentially blocking the beta-1 receptors. Dose is usually 5 milligrams IV push, and we can give 12.5 to 200 milligrams PO BID, depending upon patient's situation. Adverse effects of metoprolol: bradycardia, heart block, hypotension, worsening heart failure, bronchospasm, and depression. So there's obviously nursing indications here. So as a nurse, I know that before I give metoprolol, I need to know what the heart rate is, and I need to know what my patient's blood pressure is, because I'm not going to go ahead and give these meds, or give this med, if the patient already is hypotensive or is already bradycardic. There may or may not be a doctor's order to do that, but as a nurse, you're responsible to know to do that. So we don't administer it without go ahead and getting a set of vital signs on our patient. And indeed, if there's problems, we need to hold the medication until we have a discussion with the provider. So here a patient is ordered low pressure, 2.5 milligrams IV push. Patient weighs 209 pounds. How many mLs are you going to administer? Now, as I said, the metoprolol, we're going to be monitoring the blood pressure, pulse, and we're going to be adjusting it periodically. When we start it, EKG every 5 to 15 minutes during and for several hours after. So the person would have to be on a monitor while we're doing this. If the heart rate is less than 40, especially if the cardiac output is decreased, the person may actually need atropine. So we got to be careful when we're giving metoprolol, IV push especially, have them on a monitor, watching their vitals. If they start to have signs and symptoms of decreased cardiac output, we're going to have to go ahead and give some atropine. We're going to be looking at I's and O's and daily weights. And we're going to be looking for signs of heart failure. And as a nurse, you know the signs and symptoms of heart failure are the dyspnea, the rales, the weight gain, the peripheral edema, and the jugular venous distension. So we're going to be keeping an eye on this. So even though the drug is ordered, we are still responsible for making sure it's safe to administer the medication. Now, amiodarone, the indications for this are atrial or ventricular arrhythmias. Dose, usually 1 to 600 PO daily. Low dose, 200 to 1600 milligrams PO daily for 1 to 3 weeks. So it takes a couple of weeks to get these people loaded up and therapeutic with the amiodarone. IV-wise, we can give it 150 to 300 milligrams IV push, IV rapid infusion, and then we'll do a continuous drip. So the adverse effects of the amiodarone, kind of unique. They have this bluish skin that can happen. They can get corneal deposits in their eyes, liver toxicity, hypo and hyperthyroidism, and then pulmonary toxicity. So you think pulmonary toxicity, we'd have to recognize then they're going to have problems with perhaps a pulmonary friction rub. They may be hypoxic. They could have rales, crackles. They could have signs and symptoms that obviously the pulmonary vasculature is having a problem. So we're going to be very diligent with assessing our patient with their pulmonary status as well. So during therapy, as with the other antiarrhythmics, we're going to making sure that we have EKG monitoring and heart rate and rhythm throughout therapy. Amiodarone is a good drug. It can really help with atrial and ventricular arrhythmias. However, it does have many interactions, and it can increase the concentrations of warfarin, digoxin, and other drugs. So we don't give this without even PO or IV. We don't give it without a healthy respect for the other drugs are on and watching for those interactions. The other thing amiodarone can do is it can actually prolong the QT interval. And that's a problem because it can actually be associated then with worsening of the arrhythmia, and it could actually lead to, when you prolong that QT interval, you can actually wind up going into VTAC and VFib. So we have to be very careful when we're giving these kind of medications. And so to be closely monitoring our patient. Diltiazem or cardiazem, indications would be hypertension or tachyarrhythmias. It's a calcium channel blocker. Usually we're giving 0.25 milligrams per kilogram. Then we'll be giving 5 to 15 milligrams per kilogram, 5 to 15 milligrams, an hour IV. And orally, we may be given 120 to 480 in divided doses. Now, contraindication of cardiazem, similar to the other medication, is the Wolff-Parkinson-White syndrome. Again, that tachyarrhythmia, we got to be careful when we're starting to block the channels that we don't wind up causing more problems or heart block in these patients. So the adverse effects would be heart block, bradycardia, hypotension, CHF, and constipation. So again, with this calcium channel blocker, we're going to be monitoring BP and pulse when we give the medication, and we're going to report prolonged bradycardia or prolonged hypertension promptly. So if this person is hanging bradycardic for a while here, or their BP is just running low, the physician needs to be notified, and we as nurses need to be aware of that and making sure the doctor is aware, and they may be having to change the dose. Adenosine, everybody likes adenosine. Indications: conversion of supraventricular tachycardia to normal sinus rhythm. Method of action: it blocks all the AV node conduction for a couple of seconds. So generally we give 6 milligrams rapid IV. We may repeat it in 1 to 2 minutes, and then we may give like 12 milligrams if we have to do that. The adverse effect when we're giving this adenosine, since we're basically blocking the heart, is the nausea, the dizziness, and they may be very apprehensive with this. When we're giving as nurses, we obviously want to make sure we're giving it in a large bore IV, like in the antecubital or a central line, monitoring the heart rate frequently. I mean, they've got to be on the monitor every 15 to 30 seconds, and we're doing that ECG continuous to see what's happening, because they're going to flatline on us. And it's given IV push with the 3-way stop clock. We got to give it fast. This is one of the few meds that I can think of that I would ever push fast, but this is one that we do it because they flatline and then it converts back over to normal sinus. And so besides the heart rate, obviously the BP we're looking at and how the patient's responding. So devices, we're also using those to help with anti-arrhythmia therapy. There's pacemakers, defibrillators, and then I will talk a little bit about biventricular pacemakers. Pacemakers are generally for bradyarrhythmias. If it's slow, we want to make it fast. and it's for pacing. Defibrillators are for tachyarrhythmias. If it's fast, we got to slow it down. Defibrillators, they can be used for pacing plus anti-tachycardial functions. And the biventricular pacemakers, generally for severe heart failure, it's the cardiac resynchronization therapy. So we're trying to get the ventricles to contract together. Pacing plus anti-arrhythmic cardiac functions and that ventricular resynchronization, maximizing the output of the ventricles with the biventricular pacemakers. So pacemakers are electronic devices used to pace the heart when normal conduction pathway is damaged. There's a basic circuit, which is the power source of the battery. One or more leads that go into the myocardium, and they're threaded through. The electrical signal is the stimulus that travels from the pacemaker through the leads to the myocardium, and then the heart muscle is stimulated to contract. What do we treat, or what rhythms do we treat with pacing? Bradyarrhythmias such as sinus bradycardia or tachybrady syndrome, and patients with complete heart block or second-degree heart block type 2. They're going to need pacing. Permanent or temporary pacemakers. So permanent pacemakers are implanted entirely within the patient's body. Most are a demand pacemaker. Basically, when they sense the heart's electric activity and it needs for a firing, they will fire. And generally, this is when the heart rate drops. And there's a preset level that they're often with the pacemaker, so that that once they go below a certain rate, that the pacemaker is going to fire. Temporary pacemakers, on the other hand, the power source is actually outside the body. And the indications for this would be maintenance of an adequate heart rate and rhythm. And these are generally during special circumstances such as open heart surgery or postoperative recovery. So there's actually wires going into the heart, but the power source is outside of the body. We may do this as a bridge temporarily until a permanent pacemaker is put in. Or if somebody has a second or third degree heart block after a myocardial infarction, which is often seen. So they're going to need some sort of pacing. So types of temporary pacemakers, there could be transvenous, where the leads are actually threaded through the arm to the right atrium or the right ventricle and attached to an external power source. So that would be transvenous. Epicardial, atrial and ventricular pacing leads are attached to the epicardium during heart surgery. So open heart surgery, you're going to see the epicardial temporary pacemakers, or the transcutaneous, which I did speak about in class. And these are electrodes, pads. They're actually placed on the patient's chest, and they are connected to an external power source. So those would be temporary pacemakers versus the permanent pacemakers, which are already within the person's body. Types of pacemakers: single chamber that uses one lead in either the upper or the lower chamber to beat the heart, to make it beat. Dual chamber, they generally use one lead in the upper chamber and one lead in the lower chamber of the heart. And then, as I said before, that biventricular, they use three leads, one in the right atrium, one in the right ventricle, and one in the left ventricle. And that is in order to get that synchronization of the ventricles and get the most bang out of the ventricles, the most cardiac output, and oftentimes used in CHF patients. And here, just an example of the pulse generator that houses the battery, little tiny computer. And each impulse is carried to the heart and make it contract. Now, this is nice to know. I'm not going to ask you guys, I'm not going to test you on this, but when you get out there in your clinical setting, you're going to hear things like, well, they have a VV1, and you're going to be, what are they talking about? But basically what they're talking about is they're talking about what chamber is paced, what chamber is sensed, the motor response, the program functions, and the anti-tachycardial functions. So an example would be a VV1. So it's ventricular pacing, ventricular sensing. Pacing is inhibited by sensed spontaneous ventricular depolarization. So it's sensing, if the ventricles are doing its thing, it's not going to do anything. There's no rate modulation, it's not going to change the rate, and there's no multi-site pacing. This kind of a pacemaker is often used with patients with permanent AFib and complete heart block or severe bradycardia. So as I said, I just want you, when you're out there, to realize when people say they have a DD1, a DDD, or whatever, you understand what they're talking about. And this is what they're talking about. What is being paced, what is being sensed, how it's responding, And so, as I said, nice to know. I'm not going to be testing on this, but I want you to be aware so you're not completely oblivious is what people are talking about in report. Now, pacemaker programming is a part of it. Here you can see they're checking this patient's history. Because as I said, the pacemaker does have that little computer. There's the wand that they put on there, and they can actually set and reset rates there. They can get the history of how many times the person perhaps went into certain pacemaker was firing, those kind of things. Pacemakers, depending upon the use, the battery will have to be replaced in 8 to 10 years. So it's another surgery, they'll have to go in and replace the battery. On Canvas, I should say, I do have a pacemaker insertion monograph, as well as a pacemaker care plans. You do need to know these. You need to look these up. I'm not going to read all these to you, but basically you need to know what you're going to assess when you have a patient with a pacemaker or a pacemaker being newly inserted, what would go wrong or what could go wrong, what complications or adverse problems could happen, and what would you be responsible for teaching your patient. So please make sure you're looking at these. That would be information that I would certainly expect on an exam that you'd be able to answer, and certainly at the NCLEX we'll be asking you things like that as well. Now here's an example of a complication that can arise from a pacemaker lead migration. And if you look, you can see the one lead is past the heart and it's hanging down pretty low. So what signs and symptoms might the patient exhibit when you see this kind of a image on x-ray? And that, as a nurse, you would be able to kind of hypothesize what your patient may or may not be exhibiting. Now, the ICDs are the implantable cardioverter defibrillator. Similar to the pacemaker, it's installed in the chest to prevent sudden death from cardiac arrhythmias due to life-threatening tachyarrhythmias. Patients at risk of sudden cardiac arrest are the ones that generally are the candidates for these ICDs. So if they have a history or the propensity to go into these bad rhythms, they're going to wind up getting an ICD. So the ICDs can prevent death from cardiac arrest, and cardiac arrest is the life-threatening fast rhythms, and it's the most common cause of death in the United States. So people, heart disease, people die from it, and oftentimes cardiac arrest. So if we can prevent that from happening, we're going to use the ICDs. They're implanted as similar to pacemaker. They deliver the electrical shocks to convert life-threatening fast rhythms to a normal rhythm. And similar to pacemakers, when you read over that care planning, that they can be affected by strong magnetic fields, but if household equipment is grounded and operating normally, they should be fine and there shouldn't be any problems around it. So once again, please refer to the care plan for pacemakers on Canvas that I have. But some possible surgical related complications with an ICD placement is the pneumothorax, the defibrillator wire puncturing the heart or a vessel, bleeding from the site, blood vessel, heart, or nerve damage, swelling, bruising, or infection at the area where the device was placed, and venous thromboembolism. All problems and complications similar to the pacemaker that can arise with the ICD. Keep in mind the ICD doesn't prevent an arrhythmia, it corrects it once it's started. And in talking with patients, you can say that like the low energy shock may feel like a flutter in their chest. However, a high energy shock is going to hurt. People have often said it feels like a baseball bat being hit in the chest with a baseball bat or kicked in the chest by a horse. And most people are going to feel it in the back of their chest. And if they are having these shocks, oftentimes they're advised to sit or lie down because they may pass out. And the physician and the patient will have to discuss what they need to do if the patient gets shocked. Oftentimes they're instructed to call the office, but if they're getting shocked more than once in perhaps a 24-hour period, they may be instructed to go to the ED. But these are specific, patient-specific instructions, but you as a nurse realize the office would want to know what's going on, and if it's happening frequently, especially if they feel like they're getting hit in the chest by a baseball bat or kicked by a horse, they're going to more than likely have to go to the ED, and they're going to have to see what's going on. Now, cardioversion and defibrillation. Cardioversion is a process that aims to convert an arrhythmia back into sinus rhythm. Oftentimes we may do chemical cardioversion, trying to give meds to see if they can get them out of the rhythm, by pushing something, maybe cardiazem, those kind of things, and we'll try and get them back into a normal rhythm. But if that's not working, electrical cardioversion is used. And that's when a patient has a pulse, but it's either unstable or the chemical cardioversion has failed and really is unlikely to be successful. So we're not going to keep trying to give drugs, so it's not really working. It's oftentimes used in less urgent cases. And AFib may be an example when we're trying to revert person or cardiovert them back into normal sinus rhythm. So they may elect to do cardioversion. So synchronized cardioversion is a very low energy shock. It uses a sensor to deliver the electricity in the synchronized peak of the QRS complex. So we basically want it on the highest point of the R wave. And when the sync option is engaged on a defibrillator and the shock button is pushed, you'll actually see like a few second delay until they get right on that R complex. And that's when the machine will deliver that low energy shock to try and get them out of that atrial fib and get them back into a normal sinus rhythm. Synchronization avoids the delivery of the low energy shock during the cardiac repolarization or the T wave. And that's important because we don't want to be shocking on the T wave, because at that point in time, there's a high likelihood that the patient could actually go into VFib. So synchronization for somebody that, we see they're in AFib, we want to get them out of that. We want to do a synchronized cardioversion, low energy, delivering on the right time of the QRS complex so that we don't throw the person into VFib. If medications fail in the stable patient with the below-mentioned arrhythmias, synchronized cardioversion will most likely be indicated. So if somebody has unstable AFib, and what I'm talking about is they're maybe hypotensive, they may be having chest pain, they're just not feeling well, altered level of consciousness, they're not doing well with this AFib rate. They may go ahead and decide to synchronize cardiovert them. Atrial flutter, atrial tachycardias, they may go ahead, or supraventricular tachycardias. They may even try to synchronize a cardioversion. So if people aren't doing well with these rhythms, they're going to go ahead and they're going to try and get them out of it, and the synchronized cardioversion is most likely going to be indicated. Now, defibrillation, on the other hand, is a high energy shock, and that's delivered as soon as the shock button is pushed. So basically, there's no delay, there's no waiting for the R wave of the QRS complex. This is just, it's going to deliver a high energy shock, and it can fall randomly anywhere in the cardiac cycle. And it's used when there is no coordinated intrinsic activity of the heart. So these people they don't have a pulse, basically. We do it with pulseless VTAC or unstable VTAC. So somebody may have VTAC and it may be fast, but they still maybe have a pulse, they can still talk to you, they're not comfortable, but we're going to have to go ahead and do something. But pulseless VTAC, we actually will defibrillate that, because that person they're going to die, or they're dying, and at that point in time we got to get them out of that rhythm. There's no time to mess around, so we're going to defibrillate them versus synchronizing cardioversion. VFib is obviously, I've said before, that's why we defibrillate VFib, or when they've tried to synchronize. But let's say somebody is in VTAC and they're still able to talk, they're not feeling good, but they're not that unstable at that point in time. And so, all right, we're going to go ahead and we're going to cardiovert them. And they try to do it and it doesn't work. And now they're in pulseless VTAC, there is no pulse, the patient's not responding. We're going to go ahead and defibrillate. So defibrillation, as I said, is used for defibrillation, but I do want you to keep in mind it is used for pulseless VTAC, which is as close as you're going to get to VFib, and as I said, the person is dying or dead at that point in time, so we're going to help them out with defibrillation. So here are some differences between the cardioversion and defib. Cardioversion elective, usually an elective planned procedure, or we have some time, we're going to try and synchronize it it's going to be synchronized on the R way. There's that delay in that shock and that actual firing of the actual delivery of the shock, lower energy joules, less damage to the myocardium. So that's why another reason why we're doing this. I mean, we don't want to damage the myocardium because you don't want to send electricity through the myocardium at a higher level unnecessarily. And it's used most often in arrhythmias, except when we have pulseless VTAC or VFib. Defibrillation is energy life-saving procedure. We are going to deliver high energy. It's not synchronized. It's immediate. It's used for cardiac arrest. More damage to the myocardium is going to happen. And we use this in ventricular tach with the unstable pulseless VTAC. The person obviously is either flipping into VFib within seconds or they're already in VFib. So we're going to defibrillate them with that. And this is just a little bit of a nursing chart. As I said, the lower joules we use with cardioversion, the 50 to maybe up to 200. Defibrillation, we're going to begin with the higher joules and we're going to ramp it up to get them out of that. The person is unconscious and it is a medical emergency and we need to get them out of that. Cardioversion on the other hand is usually the patient's awake, they're frequently sedated, so they're not feeling the shocks as much, and we're going to try and get them out of that and back into normal sinus rhythm. Now, therapeutic hypothermia. Some of you may have had experience with this already if you're working in the PCU. After cardiac arrest, generally healthcare providers and patients, loved ones, we're all happy. Patients survived the cardiac arrest. They were co-blue. We were able successfully to resuscitate them, and now they're perfusing again. But unfortunately, there's usually a cerebral ischemia and hypoxia that can occur after cardiac arrest. And why is that? We refer to this as a reperfusion injury. So basically, a reperfusion injury is damage observed after restoration of blood flow to ischemic tissue. So these tissues have been anoxic, and suddenly we're putting this nice warm blood back through there, and there are pathological changes that lead to vascular dysfunction, hypotension, organ dysfunction, and cerebral edema. So it's an inflammatory response that happens after we start putting blood back into these ischemic tissues. And really, neurologic injury contributes to the mortality of inpatients post-cardiac arrest, in addition to multiple organ failure. So we had them, we successfully resuscitated them, but we can't forget about the fact that now there is the problem with the reperfusion injury. There's going to be neurologic and more organ damage that can happen. So we've got to do something about that as best we can. So therapeutic hypothermia is what we're trying, or what we do now. It is a process of cooling the body by reducing the body temperature, like to 32 to 34, maybe around that range, within 6 to 8 hours after the return of spontaneous circulation. And we're going to continue to cool the body, generally for 12 to 24 hours. Please keep in mind that the protocols vary from institution to institution, but I'm giving you kind of the big picture look of it, so if you at least understand what we're talking about. So this may not be exact where you're at or the unit you're at, but just realize that we're going to cool the body because of that reperfusion injury that can happen, and we're going to keep it cool for a little bit a while. What it does, why are we even doing this? It's hypothesized benefits, or there's research continuing on with this, that it does suppress the inflammatory reaction, so it decreases cerebral edema. It saves the brain. It can decrease oxygen consumption and decrease ongoing cerebral ischemia. So that's why we're going to do the therapeutic hypothermia. Generally, there's induction, maintenance, and rewarming. And clients must have hypothermia. They must have control. We have got to really control that. And when we're inducing them, we're maintaining them, and we're rewarming them, because there are potential side effects that can happen. They can get into arrhythmias, skin breakdown, rapid fluid electrolyte shifts, especially during the rewarming phase. And the temperature's got to be monitored. And they may be doing it through esophageal, bladder, or pulmonary artery catheter. So somebody may have a Foley catheter in with a bladder temperature probe that's in that special catheter, because we've got to keep an eye on this. So these patients obviously are in an ICU setting because they require a great deal of care and monitoring. The goal is to get the patient cooled as quickly as possible. Some institutions use ice packs, ice lavage. They may do a cold infusion. There is non-invasive cooling devices such as cooling blankets, wraps, or gel pads. The intravascular catheter may circulate cool fluid in a closed loop within a large vein. So it depends where you're at, what they're doing. Generally, though, we do know that we're going to have to sedate the patient when we're doing this, and with a neuromuscular blockade as well, because with the cooling comes the shivering. And that's just a natural body's response, right? And this allows rapid cooling to a target temperature, but with the shivering, we can actually have more problems. So we don't want to have the patient shivering. So we're going to want to give them we're going to sedate them, we're going to do a neuromuscular blockade so we don't have the shivering. The induction phase generally causes some mild diuresis. And so we got to keep an eye on the fluid electrolyte balances. So the CVP pressure, central venous pressure monitoring. And volume replacement may be needed because they could be hypotensive. Again, these people are going to be in the ICU setting. We're going to be looking at fluid electrolyte statuses. We're going to be giving them neuromuscular blockades and sedation. And we're going to use the pads or whatever the institution calls for. During the maintenance phase, we're trying to keep the patient generally within 32 to 34 degrees, and it's very crucial to keep them there. And this phase generally can last up to 12 hours to 24 hours, depending upon the target temp and whatever facility the folks may be working at. What's nice is these automatic invasive or non-invasive methods that can actually keep the patient within range. And some of you may be working with the Arctic Sun in your clinical settings. You may see them putting these on patients. And this is an example of the Arctic Sun. It's non-invasive temperature management system. We want to induce hypothermia in comatose patients that have suffered from a cardiac arrest and patients at risk for ischemic brain damage. So we're going to sedate the patient, we're going to cool them, and the Arctic Sun, this is an example of what they may be using. So I'm sure many of you have used these. I know even in the neuro ICU they use this as well to prevent the ischemic brain damage. The rewarming phase, again, this is critical. The electrolyte shifts are going to be happening, and this is when those potentially lethal arrhythmias can happen. And there's a controlled warming. They're not going to just turn it, like warm them up fast. We're going to do it slowly. They're going to have to be looking for serum electrolytes, especially we're looking about the hyperkalemia. They can also get hypoglycemic because rewarming as the insulin resistance earlier diminishes. So perhaps we're giving them insulin and now they're going to get hypoglycemic because now they're getting warm again. So again, careful monitoring, volume replacement, and looking for the fluid and electrolyte shifts. So a big deal when we're using these cooling phases on our patients. Adverse effects then, fluid electrolyte imbalances, potassium, magnesium, and calcium, probably the biggest ones. The arrhythmias, the bradycardia, the AV blocks, or atrial or ventricular fibrillation. The insulin resistance can happen initially, and then they can get that hyperglycemia, and then we start giving them insulin to get them not so hyperglycemic, and then you could have with the rewarming, the hypoglycemia, because all the insulin is still circulating in the body. The shivering increases metabolic activity and increases oxygen consumption, and we don't want that. And the coagulation problems. Because we're cooling, they can cause some mild platelet dysfunction that may arise during the hypothermia, and the patient may have increased risk of bleeding. So we're going to be looking at the central lines to see if they're oozing because the thrombocytes could be damaged and there may be some platelet dysfunction. So as nurses, we're monitoring and controlling for all these potential adverse effects. But as I said, you have to be aware of what this is. No one would expect you to know the policy or the protocol. But as nurses, we're aware of what therapeutic hypothermia is and our nursing responsibilities and what we're going to be looking out for. And that's it for the presentation. And we'll talk about this more in class. Thank you.